started, so I guess let's give everybody a minute to log in. Come in from the waiting room. How's your evening, Doc?
Things are great. No problems
Oh,
whatsoever. Looking forward to
good.
chatting with you.
I'm so excited about this webinar. I really am. I've been looking forward to it all week, even through the crazy snowy weather from the north. They brought it to my front door in the south and made me consider even going southerner to you.
It was in Florida. It was freezing too, so it's I get it. Everybody was basically getting a taste of the North Pole.
I ridiculous. Well, hey everyone. Thank you so much for being here tonight. I know you're busy running practices, seeing patients. So we really appreciate you carving time to hang out with us. For those of you I have not met, my name is Caitlin Moore with Norris Medical. My role is clinical education, so I spend most of my time working directly with doctors and teams and their implant workflow. So tonight isn't meant to be a lecture or a sales pitch. It's really a conversation. My goal is to identify the kinds of questions you normally ask when you're sitting across the table from somebody who places full arch in every day, like Dr. Makepeace Charles. So tonight we're going to walk through how to identify these cases, how to make them predictable, how to simplify your workflow, and honestly, how to make this realistic in general practice. And we're lucky to have somebody who truly lives this life every day. Dr. Macepeace Charles is a board certified oral and maxillofacial surgeon with extensive experience in full arch rehabilitation, complex surgeries, and immediate loading protocols. He's placed tons of implants and teaches nationally, focuses heavily on building systems that make these procedures repeatable and efficient. I would say not stressful, especially for real world practice. He has a course coming up. Dr. Charles, can we talk about that?
Yes, fire away. What questions do you have?
So, where is it at?
So, next gen dental education is a brainchild of mine over the last 4 years coming to fruition. And it is designed to bridge the gap between clinical medicine and the business side of it. The business side of it being the thing that we never actually get to talk about as a group of dentists and practitioners. So, we're trying to take clinical excellence and marry it to business operator excellence using systems for both creating predictable clinical outcomes, but predictable, profitable clinical outcomes. So we're in Palm Beach. You'll be staying in the area close to us. There is a hotel that actually sits on the Atlantic Ocean for participants and their families. And we keep the course very small and intimate. So it's custom designed to the people, so that to the participants, so that we can essentially analyze what's going on in their full arch practices and try to get them to be the most efficient they can be and the most profitable they can be.
That's that's really exciting because you never really hear about courses that have that business aspect to it. And I was a dental assistant, so that was something that we got relied on. So isn't there something going on where you teach the teams as well?
Yeah, next gen essentially there's a component with our administrator and our one of our treatment coordinators where we actually take what the doctor is learning clinically and then we're marrying it to the business systems that go on in the practice. What is the treatment coordinator doing? What is their role? How many times are they following up? What are the scripted conversations they can have with patients to deal with the pain points that generally create a barrier to care? So that's about 2 hours of the course itself. That's done via Zoom with treatment coordinators in the practices of those 10 to 12 doctors.
Oh, that's great. So I really can't wait to pick your brain during this webinar because I have got a long list of questions. And guys, go ahead and drop some questions in the chat. We're so excited. Give me the dates for this course. That way, when I cut you off because we're getting too into it and we're going to be in for 3 hours, they know where to find their next steps.
So generally, the easiest step, the easiest process is to go to www.nextgendentaleducation.com, and then it'll give you the list of the courses, the faculty. We have a long range of both clinical resources, but we also have business resources, and many of those are integrated into the course, along with us teaching you the cadaveric placement of implants to maximize your clinical process, utilizing digital workflows, but also looking at sort of the accounting processes and the vendor relationships that you have as well to make sure that you're getting everything in a sort of a cohesive package.
That sounds awesome. And then if you guys ever need me, I'm Caitlin Moore, Norris Medical. I'll happily directly direct you to Dr. Charles, get it all squared away because this webinar, I'm about to dig in. So drop me some questions. But for now, since I'm hosting, I'm going to pick the first one. Ba-da-da-da. Let's see. For a GP, what is the simplest way to identify a true full arch candidate during a routine exam? Starting at the basics.
So there's a couple. So the couple of questions that you have to ask yourself. One is basically the first thing you're always going to address is the patient's chief complaint. But when you're looking at their ability, one, to either take care of the dentition that they currently have, in many instances, the cases that we're getting are patients that over time have lost multiple teeth, have periodontal disease, or haven't had the means by which to take care of their teeth and are transitioning from relatively terminal dentition to completely terminal dentition. So if you're seeing more than 50% of the arch that's restored or has the inability to be restored, you're looking at a patient that either is going to have to survive with partial dentures or a large full-scale oral rehabilitation, or subsequently a more predictable result at times being a full arch patient.
So, what are the common mistakes that you see when providers are identifying these patients?
Sometimes they believe everything is a full arch. So
Mhm.
really there's a number of things that go in. There's parafunctional habits that have to be addressed. There's a number of clinical things that you can identify in the patient. Is there elongation of the coronoid process? Is there notching of portions of the mandible indicating bruxism or parafunctional habits? Are those things that you should get under control prior to having the conversation and moving towards a full arch? Because once the process starts and is going, you really are moving along in a sequence where the patient has expectations. And oftentimes, once you create the expectations and the excitement and the pain points are addressed, the patient wants to speed towards a predictable outcome. Now, that predictable outcome can be marred by broken temps, a lack of vertical space, a cosmetic issue, and each of those things we want to address beforehand. So when we're identifying, go through your mental checklist is, hey, are there parafunctional habits? Can this patient take care of a full arch? Are there systemic things that I should be aware of when addressing the potential for failure, whether it be they be oral habits or whether they be medical history issues that need to be addressed or optimized with the patient? So some of the biggest issues I see are basically not optimizing the patient prior to care.
Okay, so then when do you refer?
Great question. So generally, if you're getting to a situation where you're looking at a patient who may have one, two, three different systemic issues, if is it a smoker? Are you going to be using tilted implants? Is there a lack of vertical dimension? Will you be removing bone on either of the arches? So is the interarch distance appropriate? What are their cosmetic needs? The buccal corridors, do they have a large smile line or a small smile line? Are you in a normal occlusal relationship or are you a class 3 relationship, which is oftentimes what many people we're restoring are in? So each of those, once these problems start to compound one on top of the other, there are times where once you're at the fourth sort of issue, perhaps that might be a reasonable person to work with the specialist. It doesn't mean you're referring out the whole case, you're referring out the surgery, and you're enlisting another brain to help you get that patient from start to finish.
That's a clever way to consult then, is having the surgeon and then the GP who's restoring together on that call. That way the patient feels more secure then too.
Yeah, one of the easiest ways to get a patient to say yes is to have two doctors talking to them at the same time. And there's reasonable digital tools to be used, whether it be FaceTime, whether it be WhatsApp, coordinating that with the surgeon. Oftentimes those discussions usually lead to specifically the patient agreeing to care at that time.
That's a great tidbit. So, what diagnostic records are non-negotiable for you? Like, what do you have to have from those referrals?
Oftentimes, photographs are the first step. I think not just photographs at rest, but photographs smiling. You're assessing the buccal corridors. You're looking at the amount of movement. Oftentimes, you're measuring the vertical dimension, determining are you going to open it, and if you do, what exactly other changes will the patient have? Oftentimes, the marionette lines will disappear. So it's not simply you creating function, you're also creating a huge cosmetic component. But in order to do that, you have to have the full picture. So photographs, digital records, so digital scans, CT scans are of paramount importance. Oftentimes, that also leads to the creation of an easy to use set of records so that surgery is predictable. Prolonging surgery is what we're trying to avoid by getting as much diagnostic information up front.
So then how much success is really decided in planning versus surgery?
I would probably say that 90% of surgery is planning. 10% is what's left to chance. No one knows what bone quality is. You weren't there for the first 50 to 60 years of life when this patient created the situation. You're there now trying to fix this situation in approximately 6 months. Does that make sense?
Yeah. Yeah, that does. So how much, look, I'm trying to read off the offline chat that I'm getting over here because they're getting me some good ones. Let's see. What does a standardized workflow look like compared to a freestyle approach? Sorry, we
Okay.
were having a conversation there for a
So
minute.
that's a great question. So what you're oftentimes the easiest and most predictable way is to use existing landmarks. If the patient has even 3 teeth, you can design a surgical guide. People will say, well, I can't place all the implants through the surgical guide. All you're trying to do is place the most difficult ones that you would have trouble with without landmarks. So oftentimes we use tilted implants. For tilted implants, having a surgical guide where you keep the middle 3 teeth, but then have 4 of the implants placed on either side of those teeth and placing your last one freehand takes your surgical time and overhead time and reduces it sometimes by up to 50%.
Oh, I really do feel like it's always either all in guided or all in hashtag freehand gang. I can see that.
So even with freehand surgery, so a lot of times you're going to have somebody coming to you who says, okay, well, I had dentures, I don't want dentures anymore. So using it, you can either use a freehand approach where you're using their dentures as a guide to essentially place the implants and figure out where your multi-units are going to go, or you're converting the dentures to a digital workflow where you're scanning them and essentially creating a model in exocad where you can then create multiple different types of jigs to put in the mouth so that we know predictably where we're placing the implant so that when we scan and create a digital workflow off of those dentures, it creates a predictable restorative result.
Okay, so then what's your digital workflow like?
Good question. So once you identify your lab, you have to figure out and find out who those people are and have those discussions. Digital labs will essentially take your denture and convert it into a working CAD CAM model. Once that's done, they send you that essential file back on a viewer. It doesn't require exocad or anything else. And your job is then to look at the parameters they've created and to try to say, okay, I think these are a good version of the dentures, which are much smaller, but form into an appropriate digital arch. Once that's the case, you can then either have them send you a printed set that you can place in the mouth to place your implants, or essentially, if you have a sprint ray, printing those models yourself to functionally use them in order to place the implants in the proper location for the best restorative result.
So I
Leveraging
loved 3D
digital,
printing. That was great.
yeah, leveraging digital workflow decreases your overhead significantly because your chair time decreases significantly. If you're, for example, you have a temp and within a week you misjudge the occlusion and you get a fracture of that temp, having a CAD CAM digital model means that you're not redoing and repairing the temp. You're essentially just printing another. Printing costs are reasonable. Sometimes you can print and stain your own teeth, or you can have the digital lab send you another CAD CAM model. Maybe you open the vertical a little more to prevent fracture. Maybe you increase the thickness around the screw channel accesses, but you don't have to do any of that. You're still moving forward efficiently producing in the chair over here while your digital lab is taking that CAD CAM model and altering it and making tweaks so that you can get the patient a very quick, predictable result that improves upon the bite in a very short space of time.
And your dental assistants will love painting those things, just as a side note, guys, because that was me. I liked it. I was not very good at it. It took some practice. So here's another fun question. Can a guided zygoma approach improve overall success for full arch patients who want immediately loaded?
Yes, the difficulty is so when you're looking at how you're doing your guides for zygomas, Norris has a protocol for doing zygoma guides. Oftentimes, if you're used to doing guides with a separate company, you can create screw-in guides that first basically allow you to place the first drill. Once your zygomas are generally oriented appropriately away from the orbit and into the positions that we want them to be, it becomes much more predictable and much faster. So I believe most zygomas, if you can get them to be guided, you should. The difficulty is which companies are comfortable, and this is what we teach you in the course, which companies are comfortable creating those guides for you. So we'll start with full arch because there's a complement of great instructors that teach you about zygomas and pterygoids, but you want one company. You don't want to have to go to four different vendors. So you want one that you know can help you plan your full arches, but you also want the same company to help you if, for example, you needed a bailout. You lost the distal implant. You say, hey, maybe I could use a pterygoid. You still want that company to be able to help you take the other guide that you had and convert it into something where you can do a pterygoid or you can ultimately do a zygoma.
So you and I had a question or a conversation earlier in the week, and I really want us to redo that conversation because we talked about how having multiple implant companies can harm your profitability. And I know we're Norris, but there was something that spoke to me about it on a dental assisting level because it gets a little complicated for your staff.
So it's not just the staff. If you truly look at it, the most maxillofacial surgeons have multiple implant systems, but the reason they're using multiple implant systems is because we work with referral doctors. When you're working with a single system, from the perspective of ordering and from the perspective of having things available to you, where you're not stuck in a situation where you were attempting to use a specific size implant, but you need a much longer one, oftentimes you'll be ordering and reordering different sets of implants. So for all those doctors, when you look in that back room and you find, oh, there's an expired implant that I didn't use, it was an 8.5 I thought I was going to use. Ultimately, you did not. There's a significant waste with those parts and pieces, and there's a significant carrying cost with having four different systems and an appropriate number of implants available to you to get the best clinical outcome.
I appreciate that insight so much because I was military, and so the continuity of it spoke to me, and I never understood that reason until you and I had that conversation. So that insight was super helpful. Oh,
And
here's
your
another
staff
one
will,
from the
and your
chat.
staff will thank you.
Yes, that part. It was so much easier when we switched. It was one system, and I remember running to the logistics department in the military, panicking, looking for which round base, and then, or was it this implant system, or was it this one? And that stressed me out. Okay, so what is the ideal height of the multi-unit abutment in a full arch?
The smaller, the better. I think ultimately the most regular size that you're going to see is 2 to 3 millimeters. Depending on the amount of the soft tissue profile as it heals, if you're using a digital conversion method, oftentimes you're not just scanning the position of the implant, but you're scanning the soft tissue profile. The hard part about using taller multi-unit abutments is sometimes the soft tissue profile will shrink over time. The issue is once your CAD CAM design is based on a specific size of multi-unit abutment, the difficulty you're going to have is as that tissue shrinks, you're going to end up with a portion of that abutment showing. Now, it should be hidden underneath the transition zone of the lip, either on the lower or the upper, but it still is an interface between the prosthesis itself and the multi-unit, which sometimes catches food because it's not intimately related with the soft tissue. So the answer is at times you will have to go with the shortest multi-unit, and at times you have to change them out. So usually 2 to 3 is probably where I sit because the biological width should be between 2 and 3.
Oh, very nice. Oh, look, and then now we got, can you comment on your team structure and key roles you think are vital to deliver complex surgery and optimize outcome and patient experience. What role do you have in this besides the consulting, planning, surgery, and post-ops? Are any key pearls in patient flow management would be appreciated?
Uh, Train your staff, and then when you're done training, train them again, and then train them again. One of the things that we don't always do well is identify the strengths for key team members. There are some that have a significant amount of emotional intelligence. They're going to be able to speak to the patient's needs, and they're going to be able to deliver care on the business side. Then moving from the business side, you then have to convert that into clinical acumen. So a set of checklists is the most important thing you can have for an initial visit. And then separately, a checklist that you have specifically when you convert the patient from not just a business or clinical thing to a, or vice versa. So if there's a clinical acumen person that you have, that's your treatment coordinator, then there has to be somebody with the same surgical acumen for these types of cases to transition them from somebody who's delivering care with regards to the patient's needs to what their surgical needs are. So when they're coming in the door, there's a specific patient that a specific staff member you want in the room. And then when you're trying to figure out how the process goes, there's another surgical team member that you have. So no matter what, they're two different people, but they're both intimate related to the process. You should be the quarterback, you should have a tight end, and you should have a running back, if we liken it to football.
I like the football reference. That's great. It's like you're carrying the patient and making them feel comfortable. So it's just the flow is there.
That's part of it. So then the question is when are you collecting data? At first, you're trying to collect the data on the patient's needs. Secondarily, you're then collecting clinical data, and then you're working hand in hand with finances, and then you're moving the patient through that process. From the time they hit the door to the time you're doing surgery, you would hope that would be within a week to 10 days time, including photographs, payment, financing, planning, and ultimately execution.
Okay, so we talked about finances. So how, from a practice owner, did adding full arch change your practice financially?
So the goal oftentimes, if you look at general dentistry across the board, if you're running at a 60% overhead, you're doing great. If you're running at 70, you're probably about middle of the road. So we'll say the person at 65%. If you're quote unquote collecting $1 million and $650,000 of his expense, that means that your profit margin is probably about 35 cents on every dollar. The reason procedures tend to become more and more popular is because they're bigger ticket items. As we get bigger ticket items and we can control our costs, then your profit margin on some of those bigger ticket items is up to 50%. So the goal is for the upper line to increase, but not for the lower line to increase at the same rate. So for us, we use two different models. So we have an in-house referral model, but we also have an external marketing based company that projects leads that come into the practice, and sometimes those leads are converted. So when you start looking at the metrics of it, there's a cost of acquisition associated with some of those things. And our goal was to, yes, do more of these types of procedures, do them well with very few complications, therefore increasing the bottom line, but not spending money on complications. Does that make sense? So our practice
Yes.
changed. We probably did 40 to 50 to 60 full arches very, 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 very quickly. The issues at times is you have to make sure your infrastructure follows, or else there's small gaps that get created. So it's consistently revisiting the process and making sure that your treatment coordinator is explaining things appropriately. The patient is consented and understands what the goal of treatment is. You're not going to always make them 40 years younger, but as long as that's conveyed to the patient, then we get an appropriate clinical outcome. Secondarily, we want to look at our vendors. What are our costs? What is our lab costing us? What is our turnover time? Are we having issues in that turnover? If so, is my initial bill for that vendor the same as my bill 4 months later? So sometimes you want to make sure that essentially, even though your practice is doing better, that many of those other metrics are still followed. And that's what we have a tough time doing. Operating and watching the business side of it is where the difficulty tends to occur. So it's done wonderful things for our practice, but we've also been doing full arch for the last 15 years.
Yeah, so there's been a lot of learning from that. So I appreciate this is why I was so excited about this, is because man, there's so many of those gaps that you have in the day-to-day private practice when you're building this, that getting through those gaps can almost kind of make it defeating if you don't like jump through them, if there's high turnover with your staff or whatever the situations are. COVID again, let's not knock on wood. So let's see, how do you evaluate whether a full arch makes sense as a service line for a GP practice versus continuing to refer?
Clinical comfort. So the easiest way to go about starting your first full arch is to understand essentially what you're looking for. In every single GP practice, there are full arches. There are simple ones where the patient can do with 5 implants. There's a wide space between the mental foramen, and it's simple for you to get those in there, getting those implants in position using all of the digital tools and resources I've just discussed. That's the easiest case to do. It's not on the lower, it's on the upper. It's avoiding the sinuses. It's a patient who has a low smile line so that you're only putting one molar in on these cases. Those are the easiest patients to start with. Once you identify them, they're going to come in 6 months as recalls. So the point is you identify it in your chart, discuss the possibility of full arch. Take a free CT scan on the patient. Take a look, see if you can put the implants in, where you can put them in. Understand you want a minimum implant size of about 3.75. Literature shows that you'd love a wider implant, but oftentimes a longer, thinner implant with a reasonable connection size will get you as far as you need to go. That patient is yours. They're in your practice. And oftentimes, if there's 5 to 10 full arches, they're actually right in front of you.
So another one from this chat, what soft tissue mistakes do you see most commonly?
Most of the time, the implant is either misplaced or angulated improperly, creating a lack of soft tissue. When there's a lack of soft tissue over time, there'll be redness, swelling, and there'll be peri-implantitis. So oftentimes, the best planning leads you away from soft tissue injuries, or excuse me, soft tissue profile difficulties. So as much as you can, plan the implant in attached tissue. Even if you have to plant it in attached tissue and use a more angulated multi-unit abutment, you're still better off doing that than violating the biological width, because that creates chronic problems that are difficult to fix.
I like that. Tissue is the issue, is what they say, right? So then how do you determine 4 versus 5 versus 6 implants for stability?
Say that one more time. I'm sorry, repeat it.
How do you determine 4 versus 5 versus 6 implants for stability?
So when you start looking at the cost of care, when you start looking and saying, okay, is it easier for me to keep an arch at the exact same cost but yet throw in an extra implant? When you look at the implant cost versus the cost of having to take your time to redo portions of the arch because you don't have enough implants in the positions you need them to, it's much easier to put in more implants that are appropriately planned than it is to put in fewer and start over.
Mm. Oh, okay. Now we're going back to the tissue. What about surgical approach and preserving KG?
So generally, oftentimes people want to use a guided approach where they're not making incisions. Bone-based guides are viable, but they're cumbersome. If you have a lack of attached tissue, you're going to be making incisions and you're going to be repositioning that attached tissue. Oftentimes, you may have to augment with soft tissue or connective tissue grafting around the multi-unit abutments while you're in the temporary phase, and trimming back the temporary to make sure that you're having stable tissue around your multi-units.
Oh, this is every time I talk to you, Doc, I learn so much and I feel more confident in my skills, and to honestly, because we get good training, but now that I understand the logic behind these doctors who have kind of helped build my career, it brings a whole new eye opening to the business side of the world. So I really appreciate these questions that we're getting. So Okay, here's another one. If a GP wanted to make a full arch predictable, profitable part of their practice this year, what systems or skills would you focus on first?
First, you take the course on February 28th so that we would spend time together talking about it. Second, following the course, you'd have mentorship. So you'd send me the photos, we'd go over the CT scans, and that's exactly what we'd be talking about. So you have to figure out as a GP, am I going to use an internal system? Am I going to use an external system? If so, what exactly does that look like? Is my infrastructure actually ready for the number of patients that I may be undertaking? And if so, what time frame would that take? Am I comfortable with implementing systems and then taking a month? Is it 2 months I should take to get started? And if so, do I have the appropriate people in place with the appropriate systems to get me from start to finish? That's what determines how long it's actually going to take for you to start your first full arch.
So then let me start with this. What is a realistic revenue impact for a GP adding just one or two arches per month?
Your top line revenue can increase by 200 to $220,000, depending on how much you're charging for the arch. If you selectively choose the right arches to do and you send out the rest, the goal is to have a very predictable process where you're roughly running your costs at closer to 40 to 50% of the total revenue. So you're looking to get 100,000 in profit or somewhere around there. And that depends on the practice. That's why Next Gen is designed to be a smaller course so we can focus on your practice so that you understand exactly who has to be in place where. You're getting our checklist so that you know exactly what you're trying to create, and then you're launching a program. You're not just taking a course and understanding how to do something, you're actually understanding how to actually implement it in practice in whatever way that you want to create it. I think there's a question here about inadequate vertical reduction.
Yes, that was my next one. I keep switching you from business to clinical.
That's okay. That's the whole point. So
I'm very excited. Let's
going
go.
all the
How
going
often
all
do
the
you
way
see inadequate vertical
vertical
reduction
reduction.
resulting in prosthetic complication for our viewers, Doc?
So remember the first question, and Marshall, I don't know if you were in the chat yet. What your clinical photographs have to both be static and dynamic. What you're talking about when we talk about inadequate vertical reduction, most of the time it's not in a static phase, it's in a dynamic phase. So when you're measuring essentially where those implants go at the platform level, you have to be understanding that, yes, the patient's going to smile. And when they do, the whole point is for that transition zone between your prosthetic and your implants to be hidden under the lip in FP3 arches. So it does happen a lot, both from the perspective of cosmetics, but it also will happen a lot when you're looking at trying to figure out how to open the vertical enough so that you can have an appropriate level of cosmesis, but also the ability to have an adequate thickness of zirconia for your prosthetics. So, to your point, it's a huge issue if you don't create enough room. But all of that should be planned in conjunction with your digital lab based on parameters you have on your checklist. So if you're measuring, suppose you measure 60 millimeters, and you're measuring 54 millimeters, you know there's a loss of vertical and you have to open it. The question is how much you open it, and oftentimes you have to do that in your temporary phase. So when you're doing that, the question is, does their denture fit? If the denture does fit, is that adequate room, or should I be opening the vertical more? And if so, does the patient tolerate it when I do it in the temporary phase? AKA the reason it's easier to do it on a digital level than it is to do it analog. Hopefully that answers your question.
That does mine because my doctors, this part,
Yeah.
that one. Let's see. From a nope. What's There's so many. Hold on. Wait. If a GP wants to add, nope, we did that one. From an owner's perspective, when you added full arch to your practice, what changed first? Production, profitability, or case mix?
The first thing that's going to happen once you introduce it and you train the staff is going to bring you the full arches. So it won't always be you that's seeing them. It'll actually be the staff, because the greatest touch points in a practice aren't you as the doctor, it's the staff. It's the conversations they have on the phone. It's the things, it's where the assistant's speaking to them in the room before you come in because you're doing a hygiene check. So the staff will immediately begin to identify these patients, and then your job is to take your business protocol and process the patients. So essentially, they will start coming. You have to be ready and prepared to deal with that. You need to figure out how they're going to finance these cases. We go over that in the course. You're going to have to figure out, okay, if I'm taking them from point A to point B surgically, how ready is that patient? Have I done surgery on them before? Are there specific mechanisms that are going to be a problem? So, first thing is case mix. Next will be production. And then last will be profitability. The problem with our profession across the board is it follows that sequence, but the problem is we realize at the end that it wasn't profitable. Because when you're taking many of these courses over the years, I've taken them same as you guys have. And the problem is we never get to this discussion, which is paramount when you look at where our profession is going from the perspective of many DSOs or how vendors are relating to us, how insurance companies are relating to us. We have to have an open dialogue, creating our own ecosystem where we discuss how to take our practices to the next level, still delivering great clinical outcomes, but worried about how exactly longevity wise our practices survive.
So then we brought up insurance. So do you have any tips and tricks for insurance and really getting them? Because we all know it's kind of a hard time for the staff because filing insurance is a pain. So what are your suggestions then?
Well, insurance is part of the equation, but oftentimes with full arch, the patient's aware, they have done their due diligence. And most of the time, when you're, for example, looking at success stories, you'll have your first one, your second one, your third one, and you're documenting them, and the patient is able to sort of look at those. It's the pain points that are addressed that they focus on first, not their insurance. So your goal when you're first bringing the patient in is to create enough value that yes, his insurance is a discussion, but it's not the primary discussion. So yes, they have $1,500. They have $2,000. There's no problem with that. There's still another $20,000 that has to be financed to get through the arch. So you might spend most of their insurance benefits on teeth. That still leaves the implants.
So then do you work with financing companies and then how do you develop that relationship?
That's a tricky one. I think you have to look at practice demographic by practice demographic. And that's why the broader discussion is difficult to have here. It has to be something where we look at, hey, this is where you are. These are the types of things that are available in your area, whether it's uh, Cherry, Lending Club, whatever, Care Credit. Care Credit isn't a good one, but it's not a great example. But that's what essentially the treatment coordinators in our office go over with your office staff. And it's included in the course. So it makes no sense for those people not to be logging into a Zoom just the same as this, having these same discussions so that we create this sort of ecosystem that works for each of those practices.
Yes, full team training. I'm all for that. That's something that definitely is missing. So can we get a idea from consult timeline to surgery, setup, procedure? How does that look like in your office? And what's the entire like timeline? How much is it a month? Is it a week that that patient's back in that chair from consult to finish?
So it depends on whether you're doing an analog protocol or whether you're using a digital protocol. Um, Onboarding with digital isn't the easiest thing at times. I think as a profession, we've sped towards it because it's novel, it's new. We all have scanners. The question is how do those scanners translate to us being faster clinically? So in an analog fashion, okay, suppose the patient comes in and you're taking upper and lower impressions, or you're just duplicating their dentures. And you're saying to them, okay, well, we're going to use these as a guide for where we want to go. We're then taking those dentures, we're putting the implants in the appropriate position. We can sometimes duplicate those dentures in different radiographic material and use those to sort of decide where exactly we're going to place our implants by simply putting them in the mouth and taking a CT scan. So the faster and more comfortable you are with these protocols that we go over during the course, the faster you are at getting the patient from point A to point B. Do I think it should take longer than 2 weeks? No. It really depends on you. Scanning a patient, getting a guide, and then getting them into the chair for surgery can take approximately 7 to 10 days. If you're comfortable with the software to plan many of these, whether we talk about XNav, which sometimes we use in the practice, or protocols of this nature, it can be even faster, up to a week.
So then, as a referral-based specialist, how do you balance restoring your own arches versus maintaining referral relationships?
So we don't do a ton of restoring of our own arches. I think there's some cases where some of the we work heavily with prosthodontists. We do work with some very, very competent, successful general dentists who do a wonderful job of doing things. I think that the most important thing that you can do is say to them is when you're referring some of these patients to them, because oftentimes we're also identifying patients, we're sending them back to the referral and saying, hey, is this something you're comfortable with? Sequencing wise, a lot of times when we're moving to a digital arch flow, so we have our own photogrammetry. So if the GP doesn't have that, oftentimes we're planning in a digital fashion together, and the temporary may get screwed in our office, and the final may just go to the general dentist. It really just depends on what involvement they want in the process. Most GPs want, I'd say 85% of them want to do those cases and want to be involved, but they want mentorship. So if I'm going to do 50 of them or 30 of them in a year, the guy that's doing five of them from a restorative perspective wants you to do it hand in hand with them. And I think that's the best care that you can deliver to any patient is the more heads, the better. So if you're working congruently with the lab and then you're planning and the dentist is planning, I think it's hard not to come out with a good outcome. So some of those, the dentist is like, no, please just handle it. Can you manage it for me? And that does happen sometimes. I would put it at sometimes.
Sometimes. So then we bring up immediate loading now. What are the key requirements to confidently immediate load same day?
Again, I'll always go back to planning. The hardest part of an arch is understanding bone quality. So you can't read Hounsfield units to create bone quality. You can't look at an X-ray. So the difficulty is when you're planning the best possible surgery, in your mind, you should be planning how you're going to get out of that surgery if there's an issue in any one of those implant sites. And that's where the advent of things like pterygoids and zygomas help us with getting to the next phase of, okay, well, this didn't work out, or I don't have enough bone. Sometimes they're used as a primary solution, and sometimes they can also be used as a bailout solution.
So then what is your minimum torque per arch individual implant for immediate load before you consider a rescue implant or pivoting to an immediate denture?
So I would say 30 to 50 is where I want to be. I will undersize most sites, and I'll usually use the longest implant I possibly can. You'll know if you're placing more implants. So if you're at five separate implants, you have angled ones, then you have three in between the sinuses, and you have a torque value of 50, you can pretty much reliably restore that because you're also using cross arch stability to stabilize those implants. If you didn't have that, the question is, are you prepared to do a pterygoid or are you prepared to do a zygoma? And those are the questions you have to ask yourself during the planning phase. And if you're not comfortable, you think the bone quality could be problematic, you would look back at the patient's medical history. Are there issues, diabetes? Are they smokers? Is there a vitamin D deficiency? All of these things go into play to decide, hey, maybe this would be an indice where I've got three now things that it may be a problem. Perhaps this art should be done with a specialist as opposed to on my own. So the key is managing the complications through planning prior to execution. Measure 4 times, cut once.
I like that saying. I used that earlier today. So how do you make sure the prosthetic side doesn't slow down the surgery?
So great question. So when you So when you there's an entire metric that you can break down that we do in the course, so you can understand what is the cost of your time per hour. You have staff, you have lights, you have rent, you have capex expense. What does it truly cost? Oftentimes, a full arch and many lots of chairs it takes 8 hours. The problem associated with that is it feels good at the end of it. Yeah, we got it in there. The patient went home with teeth. For a moment, flip the script and now sit in the patient's seat for that 8 hour period of time. The goal should be to minimize your surgical time because it minimizes risk. It minimizes the possibility of infection. It decreases the amount of swelling. And oftentimes, if you truly take a poll for the patient, they have no problem with spending 3 hours in surgery, going home with metal caps, and coming back the next day and putting in an arch so that the lab work and the refinement is done without the patient sitting in the chair.
Okay. How long do you typically allocate for a consultation once the patient has completed their CBCT and is seated in the operatory? I'm asking from a scheduling optimization standpoint. Specifically, how do you structure your consult column to account for no-shows while keeping it consistently full without increasing excessive patient wait times? Additionally, are you integrating consultations along your regular operative schedule, or do you maintain dedicated consult blocks? In your experience, what is the most effective balance for both GP and oral surgeon to maintain efficiency while preserving a high quality patient experience?
So the question I'm going to ask back at Tara is: are you using an external marketing source? Or are you talking about an internal marketing source? So if you're looking at it from an internal perspective, there's already somebody who's triaged the patients. Oftentimes, the GP will have already spoken to the patient excessively. Okay, external lead platform. Let me finish this one, Tara, then we'll go back to that one. So essentially, that patient is generally set up for you. So you're, for the most part, that patient is there and has taken the time and is captive. The question is are you going to deal with the specific pain points? And is that patient going to get through the main issues that they're coming to see you for? Oftentimes, referring back to the GP, you'll get those pain points. 90% of what you want to know is already there if you just ask the questions. So that patient's going to show up if they're generally referred. Usually, if they're referred from a friend because you've already done an arch, that patient's probably going to show up. If on the phone, when you're discussing things with that specific patient that's been referred, your staff can figure out what those pain points are. And then Sarah and Jenna in our office will go over that portion with your staff so that by the time they get to your chair, for the most part, they should already be vetted. And we'll talk about how you do that with regards to even financing and pre qualifying people. Going to the external lead side, the difficulty is this, and this is it's not going to be addressed well in our discussion here because there's a lot more to it. It depends on the company you're using, how much you're spending, who's generating the leads, and who's converting the leads after they're being generated into your office. That will dictate how many of those are no-shows. Your no-show rate is probably 85%. Only 15% actually flow through to the practice. You'll get about 10% of the total number of leads coming in. Of those, maybe you'll convert 5%. So then the question you have to ask yourself is this really a loss leader in terms of me doing external based marketing? And that is, Tara, is an entire other discussion. So you should technically have that spot as a consultation spot, and there should be one trained staff member that's not your back staff that deals with that specific patient and peels off to talk about pain points to get them from sort of what you want to be a clinical patient, but dealing with the business end with that patient so that even if they don't come, that's just an extra person that you have in your practice that's redundant to you. Hopefully that answers your question to some extent.
So then, what role does prosthetic space planning play before you even pick up a drill was submitted?
It's the only way it works. The goal isn't to have a piece of titanium. It's not a broken leg where you're putting a screw in. The goal is to have teeth. So all planning across the board should always be crown down. So if you can't find a way to plan it from the crown down, that's not a case to do on your own. Refer it, get help, get the lab, get your surgeon, collaborate, and get a better result. Because what you're paying for when you don't is you're paying for the complication. So remember, the last metric is profitability. And when the planning and everything, when things start to scale up, you will realize at the end, wow, that was not profitable. I lost my shirt on that case. But the key is you shouldn't be doing that alone. That's the one that should be referred. Hopefully that makes sense.
Yeah. So then what are your key communication tips when you are communicating with your lab to make that full arch case predictable?
So you all of the records that we're normally taking, but I also believe video-based letters work well. The hard part is that the HIPAA compliance is an issue. So if you're sending things across a specific portal, that's HIPAA compliant, but you want your lab to be able to take photos and videos.
That's creative. I never would have thought to send a video, especially because like I'm sure a consent would suffice in order to get that over there.
Yeah,
Um,
that's part of the course too, is photographic consent.
oh yes. Do you recommend integrating a CRNA into the workflow for GPs who are already credentialed in IV sedation? Additionally, what impact does a CRNA utilization typically have on overhead and overall profit margins? And does your course provide guidance on how to properly structure and price cases to account for anesthesia costs while maintaining profitability?
Yes, because we're maxillofacial surgeons. So every single case we do, I'd say 100% of the time, involves either our anesthesia or if the patient is a complex case, whether they be zygomas and pterygoids, you don't want to take your chair time and spend it when you really could just have another practitioner there, shorten the chair time and move on to other procedures, if that's the best way to say it. But the metric is broken down in the course.
It makes you like that answer. We got some claps going on in the chat.
Okay.
So let's see what separates
But so
practices.
so another quick
Oh,
comment. So the whole
sure.
point of 10 to 12 participants in a course is for you to send all these questions before the course. And then our goal is to present you based on your zip code, what you're billing, how much chair time it takes you for us to figure out a profitability model for you in the course so that when you go back, you say, this is how we're doing it, guys. This is what's going to happen. This is how long it's going to take. This is the lab we're going to use. This is how much it's going to cost. That's the whole point of next gen. That's why it's the next generation of what we've all been doing for the last 30 years.
That's super cool. That like it bridges the gap from what's lacking to that clinical foundation. So you're getting a customized plan. So then tell me about your implant workflow system. When it comes to the implants that you're placing, what's your expectations from us with your partners, like with Norris Medical? Like, how do you directly communicate with your implant partner?
So your partner's your rep. So my
Hmm.
my rep is Ivan. So I talk to him about 3 times a week. Um, and the goal is for not just so if there's an arch, it's very difficult. The goal is for him to understand my process in the same manner as he's trying to figure out how exactly he can support that process. So doctors, we can always shout at your rep and tell your rep this and tell your rep that, but they're your business partners. And if you make them their business partners, the more you do, the more they earn. So the goal is to have them work with you and for you. And the goal is that's why 4 implant system means 4 new business partners. It's like you're marrying 4 other people. And for those of you who have been married, you're already just stuck with one and you're happy with that. So the point is stick to one, do well.
That makes a lot more sense. So back to the chat, have you ever had to turn down a patient for full arch treatment and why?
So I'll answer it 2 ways. So there's one where I will tell you not all money is good money in your practice. So when you're looking at pain points, When the list of pain points gets to be larger than five, you're at six, you're at seven, you're at eight, you may be a great dentist, but you're not special. You're special in your own mind. I'm special in my own mind, but you may not be the right person for that patient. And your goal is to have that one person in your practice with the emotional intelligence that's able to communicate, doc, hey, doc, I don't think that we're going to be able to make this patient happy. So, yes, the clinical dentistry may be done perfectly. You may have planned it with the lab, you may have done it with the surgeon. Everything looks the way it's supposed to. You may have sent me the films. I said, yeah, put these here, 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 and here. This is my plan. If you want to work with a surgeon, do it with the surgeon, see what he says. And you may still not be able to get to pain points six, seven, eight, and nine. That patient is not an appropriate full arch patient. I'll answer it the second way because I work at a major trauma center as well. I have seen a million full arches come in the door. And I understand that sometimes external marketing leads to a basic expense in your mind. Well, I just spent $5,000 this month. This arch came in the door. Well, the patient's ASA3 and is on a blood thinner. The doctor doesn't really want to stop the blood thinner, so he tells you, well, do it this way. The doctor's not a surgeon. He's just giving you a medical opinion. Those cases should always be done with a surgeon, and oftentimes one that's comfortable with the medicine. Don't take responsibility for those. Give those to that guy and make him take responsibility with you. Don't send him everyone that's like that. Keep some for yourself that you want to do, but make sure your ecosystem is strong so that when the problem comes up, that guy is more apt to help you because you're also he knows that you understand that there's specific cases that have more nuances to them. So even though you spent that money on external marketing, that might not be the one where you're increasing your ROI. You may effectively be decreasing your ROI.
So then speaking of diabetes, what is your A1C threshold for a diabetic all on X patient?
I would love if that was a single answer that we could do tonight, guys, but that took 3 years of residency. So essentially, if they're not controlled and you're worried about it, you should send a medical consult, but your medical consult has to have a specific sentence in it. This is what I'm worried about. Do you think this is going to be a problem? The issue on the other end, the way the medical docs look at it, when we talk to them, they're like, okay, well, what do you believe the problem's going to be? If it's an uncontrolled diabetic, stay far away. You don't need that case. It's going to decrease your ROI. So if you said implants are successful 96% of the time, you may put in 13 millimeter implants and it still doesn't work because their healing is not appropriate.
Oh, yes. So do you allow patients to utilize care credit or other similar services? If so, do you find any issue with it? You might have answered that earlier.
Yeah, that's a 2 hour discussion with Sarah and Jenna that probably are better served because they're the ones that are front facing with regards to those types of questions and commentaries from the patients. By the time I get in there, most of the time they know what the pain points are. I address those immediately. So when you're talking about time of consult, you can talk about 19 different things. After the first 15 minutes, they've either decided they're going to do it or they're not going to do it. But if in that 15 to 20 minutes, you're addressing the pain points that the staff told you on the phone and that the treatment coordinator went over, the financing and the money becomes the issue at the end because they will find the money. It's creating value. And the sooner you get to where that value creation is, that's when the cases will begin to flow in and in and in. Does that make sense? Okay.
Yes. So then what is the reasonable surgical time for the first 25 to 50 arches for both patient comfort and care, as well as practice profitability?
So again, it's if you keep, so there's a whole discussion around internal marketing versus external marketing. And the question is you have to establish what your goals are, just like you're doing crown down treatment planning. You have to figure out, well, where do I want to be? And what's the profitability margin currently in my practice? And am I improving on it? Or am I making it worse by adding full arch? 90% of the time, if you understand the workflow and have appropriate mentorship, you will probably do far better because your profitability will go up, not down. If you have somebody that you're going to work with mentor wise who's going to say that's not a case for you, send it, and the surgeon will appreciate that you know what you're doing, you're going to be far happier. You'll deal with fewer complications and your profitability will go up because you're not paying for complications.
It comes back to complications a lot, I've noticed during this conversation. So managing complications is definitely going to be a key from treatment planning and predictability and making sure the console is correct all the way to the back. So, oh, my favorite question of the night. Why has Dr. Charles decided that Norris is the best system to partner with in his course?
So if you're looking at it from an efficiency standpoint, it's the system that, so number one, there's one connection on it. Essentially, it's not a conical, it's a hex. Works just fine. Very predictable surface, and you have skinnier implants that are longer with a great surface that integrates well. That's first. Second, when it comes to the bailout discussion that you have to have, if something doesn't work out, I can easily pivot to a zygoma. I can easily pivot to a pterygoid because most times I've planned the arch and the pterygoid. Generally, the zygomas for me are freehand, but that's because I do this stuff all the time. So I know that there's a predictable solution with Norris for every single arch that I'm doing. You can't say, like, you can't, there's other companies that are late to the party. They're trying, and most of them in many instances are either copying Norris's design on their zygomas or their pterygoids, or they don't have a true pterygoid, or they're trying to come up with a zygoma that sort of mimics it. So that's why Norris.
Thanks, Doc. That was so sweet of you. I love that question. That was a great question. And it actually leads on to this question that I had over here in this side chat that I have going with some dental assisting buddies. They wanted to know, do you standardize your implant system? But most important, how important is simplification of your surgical kit and inventory for efficiency and margins? And then what mistakes do you see practices make when it comes to over ordering or carrying too much implant inventory?
So essentially, your dental assistants, your surgical assistants are they're your partners in the practice. So the more the more money the practice makes, the more money that essentially is available to them. So what happens is you're trying to create a situation where they too understand the business metrics. At times as dentists, it's tough. Like you're going to have staff that truly are vested in the practice, and you're going to have a tough time with some that are not. And your role is to pick the ones that are vested. Once they understand the kits and they're trained, every quarter it should sit in your Google Calendar. Go back over the kits again. Make sure they understand exactly what they're doing. Second, if you're buying your first set of implants, that money's been now expended. That becomes your consignment. As soon as you get rid of those 5 implants, you rebuy them. So you're not keeping extra amounts of money on the shelf. You're also not creating situations where implants are constantly expiring. So the goal is if I have 15 and that's what I was comfortable with, keep that 15 so that I can do a full arch upper and a full arch lower if I wanted 6 upper, 6 lower. So then I have some spares on the side if I needed. So suppose somebody had too much coffee and they dropped the implant, you have an extra. So if you're buying 15, that sounds great. Then what happens is you use them. You know that there's a portion of that you have to say, okay, well, I spent that money. It's already in my profitability model. Let me now rebuy that 15 so I'm available for the next case. So that you don't need 50 implants or 60 implants. It doesn't work effectively.
And then here is this one. I understand the guide issue. What about the utilization of navigation in these cases?
So are you talking about, so you're talking about XNAV, I think, whoever asked the question, correct?
I believe so.
So I've had XNAV probably for 8 years. So when they initially came out with full arch navigation, it was cumbersome and tough to use. The good news with the company, it's very stable. So they've had the same group of vice presidents and developers all the way to now. So XNav does work well. It just does. You can take it from your planning software, you can drop it in XNav, and then essentially you can have the entire planning system embedded in XNav. You can change things on the fly. Where it becomes cumbersome in these instances is who else is going to understand XNav besides you in the practice. So then you have to take an ancillary staff member, you now have to train them on guided surgery. Then you have to be able to, they have to be techie enough to then import it into XNav. And then what if the goal is redundancy? You get on a plane because there's redundancy. One system fails, there's two other systems there. Your staff is your redundancy. If you don't have a redundancy for the process itself, it creates issues if you miss something or if you have to change something on the fly. You're then spending more time in the chair, thus increasing your overhead. Hopefully that addresses it.
So I think that was great. So this is the final question we've gone over, guys. So everybody who stayed with us, thank you so much. What do you charge per arch? It's a trick because there's three questions in this. So what do you charge per arch? And what are you doing? And are you doing the finals on the cases that you get from direct to patient marketing? Do you run a dual arch combo price that is better than the sum of two arches?
So all of those marketing, all of those things that you're talking about are going to be based on your zip code. So if you're in, and forgive me, if you're in Maine and you're the main person doing this type of work, or there's only two of you, you don't need to alter or change your pricing. Pricing metrics are basically based on competition. Your arches, a standard arch is between $20,000 and $25,000. Now, in that pricing, we as dentists tend to compare. An arch takes me 2 hours, and then the patient is scanned, not by me, by trained staff. I'm reversing the anesthesia. That's sent out to the lab. The lab already has a working model. I've put the implants within their working model. They have that design back to me in approximately a half hour. I could then print it, stain it if I chose to. It would take me another 2 hours, but instead I choose to send the patient home, reverse my anesthesia, decreases my morbidity associated with anesthesia. The patient's happy, awake. They come in the next day, I unscrew the metal caps, and I put in an arch. Delivery takes 30 minutes.
So then I'm going to sneak in one more question. During routine maintenance of your full arch prosthetics, do you have a specific protocol timeframe for replacing the screws, or do you usually replace these screws periodically for new ones?
So it depends on whether you have, so it's a complete upper and complete lower. Prosthetically, you will at times have to replace screws. I usually will see full arches once a year. I'll check the occlusion to make sure that it hasn't changed or the wear patterns haven't changed, but we will have taken photographs of the occlusion when we're delivering it and we compare it a year later. If things are changing, you're probably going to have to start thinking about whether sooner or later you're going to have a screw issue. Do I see occlusal changes often in those instances? No. Where I do see occlusal changes often is when you're operating against either restored dentition, because when the upper dentition is changed versus native dentition or restored native dentition, you're going to get a mild amount of attrition and you're going to get altered passive eruption. When you do, there's occlusal changes, and that's when all of a sudden a screw breaks. So oftentimes, if you look at the occlusion and you watch them year after year after year, more often than not, you're less likely to have issues. Second, don't be afraid to put in a guard to protect.
Night guards for everybody. All right,
Okay. I
Dr.
just want to
Charleris.
one more. I want to answer Anthony's question if he's still in here.
Sure.
You have to decide if 25 or 50 is where you want to be. And you have to create a metric for getting to 25 or 50. You have to be comfortable with the amount of money that that's going to take from an external marketer. And you have to see, if I'm willing to spend 20, is there somebody else that's spending 30? Most the person who spends the most will get the most quality leads. The rest of the leads after that generally will go to you secondarily. It's the way Google runs the metric.
Doodle it. I love Google. So, Dr. Charles, thank you so much for hosting this with me. I really appreciate it. Every time we talk through cases like this, you realize how much full arch success really comes down to having a clear system and repeatable workflow and some good surgical skill. So, everybody listening tonight, thank you for joining. Give us one more taste about that course. It's
February
when,
28th. I'll see you
where.
guys. Palm Beach, Florida. It'll be warm, I promise. Enjoy.
Yes, let's
Take care,
escape the
guys. Thanks for hanging
cold.
out. Ciao. Bye bye.
Yeah. Me,